My name is Professor Beydoun. Today we will be discussing the complement system in NMOSD and myasthenia gravis, a target for therapeutic benefit. I'm here with Professor Heinz Wiendl and Professor Pushpa, Narayanaswami. We'll start discussing the role of complement in NMOSD and MG pathophysiology. So there are three different pathways that activate complement. Today we're going to focus mainly on the classical pathway, which is relevant to the disease state we're discussing today. Start with antigen binding to an antibody and then binding to C1q and then activation of the complement cascade. All of these pathways result in the formation of C3 convertase that then break down C3 into C3a and C3b, then formation of C5 convertase that activates C5 and break it into C5a, a powerful inflammatory molecule, as well as C5b. C5b then unite and combine with other complement components, results in the formation of the membrane attack complex that can bind to cell membrane and result in cell lysis. So here we're talking about the role of complement activation in the pathogenesis of both NMOSD and myasthenia gravis. On the left side, you see NMOSD, where you have the production of aquaporin-4 antibodies in the periphery that cross the blood-brain barrier and activate complement. These are IgG isotype with complement activation, activation of C5, ultimately formation of the membrane attack complex, which result in an astrocytopathy. But also you have concomitant powerful inflammatory process that occur via C5a, and these two processes continue in terms of complement activation and inflammatory process that contribute to demyelination, oligodendrocyte dysfunction, and ultimately cell destruction. On the right side, you see the myasthenia gravis. We have breakdown of self-tolerance at the level of the thymus. B cells produce antibodies. These are acetylcholine receptor antibodies. We're talking about the binding antibodies, the specific isotype that can activate complement via the classical complement pathway, and ultimately acting on C5, resulting in the formation of membrane attack complex that can destroy the postsynaptic muscle membrane, simplify it, and then contribute to the pathophysiology of myasthenia gravis. So we'll turn to our esteemed colleague, Professor Wiendl and Professor Narayanaswami, and we have questions from our audience. So first question, and it's really, I can address it to both of you. How does complement activation differ in patients with NMOSD and those with myasthenia gravis, and what are the triggers? So maybe Heinz, if you want to take this first, and then Pushpa.
Yeah, thanks, Said. So I might gonna give it a start. So first of all, one disease happens in the central nervous system, the other is in the neuromuscular compartment. If you look at the homogeneity of the diseases, the thinking is that NMOSD is a much more homogeneous and much more homogeneously complement-depending entity, where the complement activation also triggers the cascade of inflammatory waves that in the end lead to this destructive NMOSD-like relapses, while MG is not in all cases completely complement-driven, particularly when it comes to other isotypes and other antigens. There is more a continuous but not solely complement-driving element in MG. So that would be one answer I could give.
Great, thank you. Pushpa?
I think the additional point that I would make is that in MG, we typically don't see inflammatory reactions at the neuromuscular junction, whereas, as you said, in NMOSD, the C5 component or complement activates neutrophils and macrophages to the site of the problem, which is the spinal cord. And we do see inflammation there. So it's just another minor difference there, I think.
Great, thank you. And then the point that can be made that antibody in NMOSD tend to be tend to activate complement, whereas in myasthenia gravis, we have different kind of autoantibodies, some that are blocking or antigen modulating, and then the binding. So the pathophysiology can be different. The second question is, again, for you, Pushpa. Do you know if there are differences in the complement pattern in myasthenia gravis, meaning the generalized versus the ocular one?
This is an area of intense research now in terms of looking at complement profiles in the blood. And Dr. Mantagaza has done some work on this as well. I do think that the interest that we have in terms of why ocular muscles are most frequently involved is something that we've wondered about for a long time. And I think there are various reasons, complement being one of them. One reason is that these muscles tend to have a lower density of acetylcholine receptors, but at the same time, they are highly active. They contract very rapidly, so they tend to be fatigued easily. And they tend to have less resistance to intrinsic complement activation because there are these regulatory proteins, so complement regulators, if you will, that are present at neuromuscular junctions that prevent the activation of complement. And there are animal studies that show that the extraocular muscles may not have as much expression of these regulators, and therefore they are prone to complement-mediated damage. So some intrinsic factors in the ocular muscles themselves.
Great point, Pushpa. And really this, what we think is that there are differences between the extraocular muscles and other muscles, particularly in terms of the geometry of the postsynaptic fold, the surface area between those muscles and the other muscles, as well as the physiology of the extraocular muscles in terms of firing rate. And the great point you brought about the regulation of complement activation, which differs between those two sets of muscles. We can move on to question number 3, and this is complement activation characteristic of other autoimmune CNS disorder? And I'll pose this question to you, Dr. Wiendl.
Yeah, I would clearly say yes. I think there is an increasing notion that many neuroimmunological or neurological conditions could be also considered complementopathies, where complement activation plays a more or less dominant role and therefore is a therapeutic target. It certainly depends on, as I said, the type of the antibody that plays a role, whether it is known or not known. For example, in multiple sclerosis, there's certainly a complement activation. We don't know the prime target of antibody responses either being primary or secondary. But, and that is, I think, the aspect that I would like to highlight, in any disease where there is a relevant antibody component and where is the appropriate isotype, and that is mainly IgG1, there is a likelihood that complement activation plays a pathogenetic role that might be more or less dominant to the clinical symptomatology.
Great, thank you. And I can add here, and Pushpa will agree with me, really the question should be complement activation. Is it characteristic of other autoimmune peripheral nervous system disorders? So we know in Guillain-Barré syndrome, multifocal motor neuropathy, even CIDP, where complement activation plays an important role, but that will be another discussion if we need to go into that. The fourth question is, what proportion of patients with NMOSD and myasthenia have complement-driven disease? So Pushpa, would you want to comment on that as far as myasthenia?
Sure, I'll take the myasthenia piece here. And again, it depends. So we're talking about acetylcholine receptor antibody positive myasthenics here. So we've already narrowed down our proportion, but we know that 80% or so of myasthenics, generalized myasthenia gravis, have acetylcholine receptor antibodies. And even in those, I think we mentioned this earlier briefly, the antibodies seem to have different functions. We concentrate on complement here, but there are also antibodies that modulate the acetylcholine receptor and internally degrade these receptors and therefore have a role in the pathogenesis. There are also blocking antibodies that block the acetylcholine binding sites by steric hindrance, And so complement is the third, or if you will, another pathogenic mechanism that the acetylcholine receptor antibodies cause disease by. I'm not aware of actual formal numbers that we know that in this proportion of patients, we have complement inhibition as a primary process. But I think it's good to keep in mind that these people may have other mechanisms as well. And of course, we already talked about other antigens towards which the antibodies are directed, MuSK, LRP4. These are not complement activating diseases. I'll turn it over to Heinz for the NMOSD question.
Yeah, I would add here that we don't know from really biological assessments, but we could use the application of reverse translational knowledge. That means learning pathogenesis via therapeutic intervention. And the lessons learned here is that you're able to really silence NMOSD with complement inhibiting agents by nearly 100%, which means that probably nearly 100% of the relapse driving pathology is complement dependent. This is not that much the case in myasthenia, although the treatment effect per se is impressive, but we have a couple of patients that simply do not respond. So my answer would be the proportion of patients in NMOSD is probably approximately close to 100%.
Yeah, and I agree with that assessment in myasthenia as well. I mean, not everybody responds.
That's true. And if we knew the proportion of patients with myasthenia of complement-driven disease, we could predict the potential role of C5 blockers in myasthenia